I guess we can get started. My name is Paul Merguerian. I'm from Seattle Children's Hospital, and good morning, everyone who is on the East Coast. I guess on the East Coast it's afternoon. Just wanted to go over perinatal urology. This is going to be a very quick talk, and we'll entertain questions later on. It's a large topic to discuss. Oops, for some reason I have nothing to disclose. So this is a Life magazine front page, and there's in April 1983, so 37 years ago, when ultrasound was just starting, and there were applications of ultrasound, and was created as a surgical miracle. Antenatal ultrasound is ideally suited for GU abnormalities, mainly because the kidneys are visible by 13 to 14 weeks. We can see the bladder as a fluid-filled mass, or any type of abnormality within the kidney as a fluid-filled mass. And so it itself had a tremendous impact on pediatric urology. If we look at 37 years ago, a lot of patients 37 years used to come in as teenagers with abdominal masses or pain, and were found to have UPJ obstruction with kidneys that were barely functioning and underwent nephrectomies. It's rarely seen today. We still see those, but not as often as we used to 37, 40 years ago. Hydronephrosis is the most common congenital condition that was detected by ultrasound. Some form of urinary dilation is seen in around 1 to 100 pregnancies, and is significant in 1 to 500 pregnancies. When you look at the numbers, the majority of those, the numbers range between 75 to 80% of those were resolved by 1 year of age. And when you look at all the studies that have been recorded, the operative rate is less than 30%. So less than 30% of these children that are diagnosed antenatally will require some form of surgical intervention. What the urologist sees is this kidney with dilation of renal pelvis, dilation of the calyces. And back in the 1980s, it was felt that we should grade these, and the Society for Fetal Urology came up with a grading system that pretty much relied mostly on the dilation of the calyces. So the SFU grading system is 4 grades. Grade 1, where only the renal pelvis is dilated, like here on the right side, with no dilation of the calyces. Grade 2, where there's moderate dilation of the pelvis, and also some mild dilation of the calyces, either one or many. Grade 3, a more severe dilation of the renal pelvis with more dilation of renal calyces, but the parenchyma is intact. And grade 4, where you actually have thinning of the renal parenchyma over the calyces. And this grading system has been used for a very long time. This is an example of grade 1, where you've got mild dilation of the renal pelvis. Grade 2, where you have dilation of renal pelvis, some calyces, maybe 1 or 2. And then grade 3, more severe dilation of the calyces. And grade 4, thinning of the renal parenchyma. This has also been correlated to surgical intervention post-op, realizing that the indications for surgery are very subjective. There are some clear indications such as decreased renal function or increasing hydronephrosis or discomfort, pain, urinary tract infections. But when they looked at, this is from Ross back in 2011, and they evaluated 125 infants that presented with antenatal hydronephrosis. And they only looked at SFU grades 3 and 4 because those are mostly the ones that will undergo surgical intervention. So out of the 125, 27%, around 20% of these kids underwent immediate surgical intervention, mainly because of decreased renal function or severe delay in drainage. And if you look at it, most of these were SFU grade 4 hydronephrosis. Out of the remainder 98 that were observed over time, there was 21 of these underwent delayed surgical intervention. Again, the majority of those were SFU grade 4, and then around 2/3 of them continued observation. And when you look at the numbers, yes, the majority are SFU grade 3s, but there are some SFU grade 4s that have been followed conservatively. So not all SFU grade 4s need surgical intervention. Some of them can be observed, but we have to observe them very carefully over time. As far as the obstetricians are concerned, antenatally, what they can tell us is the AP diameter of the inner pelvis, and they've been really concentrating on the pelvic diameter in utero for hydronephrosis. And these have been classified. So the kidneys are seen between 12 and 18-week gestation. The reliably seen in the second and third trimester, and the first renal ultrasound is done at approximately 20 weeks gestation. And then those are the parameters as far as the renal pelvis dilation. So any dilation greater than 10 millimeters in the second trimester is considered to be severe, greater than 15 millimeters in the third trimester, less than 9 millimeters in the first trimester, and less than 7 millimeters in the second trimester have been considered to be mild. If you see, the majority of these are in the mild, moderate category, and a very small percentage in the severe category. As far as postnatal or risk for postnatal intervention or disease, more so in the moderate and severe category, less so in the mild category. So the milds, a lot of times, would not require any intervention. The moderate severe may require surgical intervention. I think from a urology standpoint, our job is to differentiate between those that are physiological and are clinically not significant with those that are obstructed and need intervention. Because the physiological ones do not require treatment, and we should avoid unnecessary testing, antibiotic prophylaxis, or surgery. It is the other group, which is actually the smaller group, that we would then need treatment. And the main reason for treatment is protect renal function, permit growth and development, and then avoid any type of complications such as urinary tract infection or pain. Around 5 years ago, several societies have come together to create a multidisciplinary consensus on the classification. It was felt that the SFU grading classification did not address all the components of collecting system dilation, and so all these societies came together and came up with what is called a UTD classification system. The UTD grading system has 6 clinical relevant features. It looks at the APD diameter, the anterior posterior diameter of the renal pelvis, the appearance of the parenchyma. Are there cysts in the parenchyma? Is there dysplasia? Is there thinning of the parenchyma? It looked at parenchymal thickness, which is a subjective assessment. It looked at calyceal dilation. If the calyces, are they centrally dilated? Are they peripherally dilated? They looked at ureteral dilation. Is the ureter normal or abnormal? Looked at the bladder. Is the bladder normal, abnormal? Thickness of the bladder. Is there something else in the bladder, such as uretero or dilated posterior urethra? And came up with what is called the UTD classification system. And it's UTD-P1, UTD-P2, and UTD-P3. If you compare those to the SFU grading system, just one grade lower. So UTD-P1 is usually a SFU grade 2, UTD-P2 is an SFU grade 3, and UTD-P3 is similar to an SFU grade 4, but the grading system is a little bit different in that it adds all these components to the grading system. So when we look at the postnatal presentation, UTD-P1 is thought to be low risk. Those are ultrasounds that are done beyond 48 hours. The AP diameter is less than 15 millimeters. There's only central calyceal dilation, not peripheral dilation. Those are low risk patients, that are UTD-P1s. The P3s on the right-hand side are those that are at high risk. Those are kids that have AP diameters of greater than 50 millimeters. There's peripheral calyceal dilation. The parenchymal thickness is abnormal. Either there are cysts in the parenchyma or the parenchyma is thin. The ureters may or may not be abnormal, or the bladder is abnormal. In the middle are the intermediate risk of UTDP2s. And those are kids that have, less than 50 millimeters dilation. There's peripheral calyceal dilation. The ureter may or may not be normal, but the renal parenchyma is normal, the bladder is normal, and those are classified as UTDP2s. So the management has changed into a risk-based management. With the UTDP1s, we usually follow these with ultrasounds, maybe every 6 months. VCUG, and these are not recommended. Antibiotics are not recommended. And renal scans to look for function is also not recommended. For the UTDP3s on the right-hand side, we would recommend very close follow-up, but possibly an ultrasound, repeat ultrasound around a month. We would recommend avoiding cystourethrogram to look for reflux. Antibiotics in this high group is recommended. There are several studies that have shown that there's a higher rate of urinary tract infection in this group. And functional renal studies are also recommended in this group, but that's at the discretion of the clinician. I think when you look at hydronephrosis, you've got to look at it not as a single shot and single exam, but serial exams. And if there are changes on the serial exam and in the UTDP3, what I usually do is I would repeat an ultrasound once or twice. If there is no change or there's an increase in the degree of hydronephrosis, then I would get a renal scan to evaluate function and drainage. For the UTDP2s, again, a follow-up ultrasounds every 3 months. The VCUG is at discretion of the clinician. The antibiotics are at discretion of the clinician. And I think this slide is probably wrong because the antibiotics is at discretion of the clinician together with the family. So it's really important to talk it over with the family. There are several families that are today not comfortable giving prophylactic and antibiotics, and we can talk to them about that. I usually tell families that with the UTDP2s, if we actually follow them conservatively with just ultrasounds, realize that around 20% of them will have vesicoureteral reflux. Most of these are clinically not significant, and therefore I would not perform avoiding cystourethrogram. But if they do develop a febrile urinary tract infection, that is maybe an indication to actually get a VCUG in this group of individuals. Braga from Canada has actually looked at the comparison between the SFU and UTDP system. They pretty much compare equally. Around 30% of them, the UTDP2s and P3s versus SFU grades 3 and 4 will require surgery. And the UTI rate in this higher group, the SFUs 3, 4, UTDP2s, 3s, the rate of UTI is around 8 to 10%. When you look at the etiology of moderate to severe hydronephrosis, the majority of these are due to ureteropelvic junction obstruction. Around 20 to 30% are due to vesicoureteral reflux, a small percentage due to obstruction, an even small percentage due to multicystic dysplastic kidneys, around 5%, duplication anomalies, and valves are found in around 1 to 2% of antenatally diagnosed hydronephrosis. And what can usually happen with those is, for example, an SFU grade 3 or UTDP2 hydronephrosis, those can resolve over time. On the left-hand side, you notice that there's dilation of renal pelvis and calyces, and 1 year later, the kidney is normal. On the other hand, you can get those to become significantly dilated or have decreased function on nuclear medicine study, with the ureteropelvic junction obstruction being the most common, that may require surgical intervention. There's one other entity that I'd like to discuss, is the fact that we should repeat another ultrasound if the initial postnatal ultrasound is normal. meaning that if, for example, there's prenatal hydronephrosis, you get a postnatal ultrasound at 48 to 72 hours later, the ultrasound is normal. Our recommendation is to repeat this ultrasound a month to 2 months later, because around usually 5% of these kids will have hydronephrosis that will develop at the 1 month ultrasound and was not present at birth or during the first week of life. And so our recommendation is to repeat these ultrasounds to make absolutely sure that the hydronephrosis is indeed resolved. As far as voiding cystourethrogram, I kind of discussed it in the UTDP2s. I think the voiding cystourethograms are indicated if they help us in determining clinically significant abnormalities. So those are kids with significant dilations greater than 15 millimeters, because we'd like to know if that dilation is due to reflux or is it due to ureteropelvic junction obstruction. Those with bilateral hydronephrosis, especially the males with bilateral hydronephrosis, to rule out posterior urethral valves. Those with dilated ureters, those with abnormal bladders, because they may have neurogenic bladder secondary to valves. Duplicated system with hydronephrosis, because that helps with our management of these cases, if they do have reflux to the lower pole of a duplicated system or not. Those that have abnormally echogenic kidneys or small kidneys. As far as MAC3 renal scans, which is a scan of choice for evaluating function and drainage, again, UTDP3 hydronephrosis may require MAC3 renal scan. As I stated before, I usually would get a couple of ultrasounds before proceeding with a UTDP3. And again, the MAC3 renal scan is more accurate if done later, so you can wait 2 to 3 months to get the MAC3 renal scan, unless the hydronephrosis is severe enough that you think that MAC3 is warranted earlier. If there are small scarred kidneys or small dysplastic kidneys, the renal scan may be adequate. An interesting thing, you can talk about DMSA scan for performing this versus the MAC3 renal scan. What I found is that the DMSA scan has a significantly higher rate of radiation to the child than a MAC3 renal scan. So I've pretty much switched to MAC3s unless I'm looking for something specific for a DMSA. There's a size discrepancy or high-grade vesicoureteral reflux. As far as kids that we should watch very, very carefully, because most of these most likely will require some form of surgical intervention. Those with bilateral hydronephrosis, especially if the AP diameter is greater than 20 millimeters. Those with a solitary kidney and a significant dilation of 15 millimeters or greater. Those that have high or dilated ureters. Those that have a differential function that's reduced, and the small echogenic kidneys, as we'd like to protect renal function as much as possible. So if you have a patient with SFU grade 3 or 4 or UTDP2 and P3 hydronephrosis, a renal scan, as I said, is usually performed. I think we perform the renal scan after serial ultrasounds. If the diuretic renal scan is normal, we would then follow these kids with repeated ultrasounds. If it's abnormal, you would follow them with ultrasound and then repeat the serial diuretic renal scan. And the main reason for performing that is to evaluate renal function to see if it's stable or it changed, because if there's greater than 20% change in renal function, that in itself is an indication for surgery. And again, if the surgery is indicated for poor function or significantly delayed drainage. So this is an ultrasound of a UPJ obstruction. I can actually see the dilated renal pelvis with an obstruction right there. UPJ obstructions can be either intrinsic, which is the most common thing with neonates, either the dysplastic segment at the ureteropelvic junction or a high-riding insertion, or could be extrinsic to crossing vessels. Those are usually seen in older children. I've seen a few kids that have had mild hydronephrosis, antenatal diagnosis, postnatal ultrasounds, and then develop severe hydronephrosis to crossing vessel at a later age, and that can happen. This is a significantly dilated system. You notice that the calyces are dilated, very thin parenchyma due to UPJ obstruction. Nuclear medicine studies are performed on the MAC3 renal scans. The important thing with those is that kids need to be hydrated. We would always place the catheter in the bladder to drain the bladder, because that can skew your results. And then Lasix is given. Most institutions will give it at the peak. There are different ways of giving Lasix, but most of the time you just wait until the radionuclide peaks within the parenchyma, and then give Lasix. So this is an example of a kid with a duplicated collection system that has a UPJ obstruction of the lower pole, and as you notice, the counts keep on increasing after insertion of Lasix right here on the right-hand side. And you can see on the study that you have a ureter and then a very dysplastic segment right there that is causing the obstruction. MR urography has been popularized in the last several years in evaluating kids with hydronephrosis, and this is a really nice a study that can give us both function of the kidney, can give us drainage from the kidney, and a lot of institutions have substituted this study to the MAC3 renal scan. The only disadvantage is in older kids, this needs to be done with sedation. And then the other thing that the MRU can detect is some abnormalities, such as over here fibroepithelial polyps. And you can actually render the renal pelvis and look at and do some modeling of how the ureter and renal pelvis hook to each other. That could prepare you for surgical intervention. For example, on the right-hand side, this is significantly dilated renal pelvis. Your incision may be a little bit lower than where you would initially. As far as treatment is concerned, the pretty much surgical treatment, there are two options. Surgery, if there's significant hydronephrosis on the ultrasound, or if there's decreased function of the kidney, and those that do not have any of that, we would then watch them with serial ultrasounds. And if we do get MAC3 renal scan, a decrease of 20% indicates surgery. Again, a lot of people would argue this is already too late, and we don't have any studies to date that can actually determine and tell us which kidneys are going to do fine, which are not. And so I think with these kids, it's extremely important to watch them conservatively, but very carefully. When we look at numbers, most kids, if they will undergo any type of surgical intervention, will do so within the first 2 years, absolutely up to the first 4 years. And so in the first 2 years of life, it's really important to watch them very closely. Initially, we would get an ultrasound every 3 months for the first year, and then if they're stable, space them out a little bit more in the second year. This is an example of ureteropelvic junction obstruction. Those systems can be significantly dilated. You'll notice the kidney is normal in appearance, and the common operation is the Heinz pyeloplasty, pretty much dissecting, excising the dysplastic segment and re-anastomosing the ureter up to the renal pelvis. This can be done either with open procedure, laparoscopic, or robotic. The two most common today are open for the younger kids and robotic for the older kids. For the infants, we can do those in very tiny incisions. And I think our incisions are around 2 to 2.5 centimeters. You can bring the pelvis up to the skin level, perform the anastomosis, and then put it back in. And then the robotic surgeries are done also with small incisions, and they're appropriate for the older kids. The different institutions have different indications. Our indications are 6 months or older. We would refer them to the robotic surgeons. Anyone that's under 6 months most likely would benefit from an open pyeloplasty. These kids go home the next day and their pain is pretty well tolerated. The second abnormality that I'd like to talk about is ureteral dilation. As you know, this could either be an obstructed megaureter, refluxing megaureter, or none of the above. Most of them today are diagnosed antenatally. Some will present later on with urinary tract infections, stones, or hematuria. This is a renal scan that basically shows the kidney and the dilated ureter. Some of them do get obstructed and require surgical intervention. Those are with delayed drainage. And again, they're usually due to a dysplastic segment, or a segment does not work, does not peristalse, that cause a primary obstructive megaureter. These can be really dilated, such as this one in this picture. This is, you just notice the dilated ureter and dysplastic segment of ureter. These types of operations for the obstructed ones, different ways of dealing with the operation. This is a tapered ureter reimplantation performed. But one thing to remember with the megaureters is that 80% of them will get better over time. So this is this is a kid with a severely dilated system on the left side, and then this is that's an IVP. When IVPs were done, you notice that ureter has decreased in size. So 80% of these will get better over time. So most megaureters we would follow conservatively, even those that have delayed drainage, as a lot of them will get better over time, and only operate on those that have decreased function or significant increase in degree of dilation over time. Cystic kidney disease, the most common being this, which is multicystic dysplastic kidney. The important thing to note is they look different on ultrasound than the UPJ obstruction. With the UPJ obstruction, you have a central dilated pelvis and dilated calyces. Here, the cysts are randomly within the kidney, so you notice they're everywhere in the kidney. It's a classic finding in dysplastic, multicystic dysplastic kidney. In the past, these kidneys were removed with thoughts that they can lead to cancer, but this has been proven to be wrong. And currently, our management of these is observation with serial ultrasounds. These usually regress. The risk of malignancy is very small. The risk of hypertension is also small. And there's really no risk for urinary tract infection or any other abnormalities. We would recommend a nephrectomy only if they are so large that they cause a problem with respiratory or feeding problems, but they fail to involute, they don't go over time. This may be a more cost-effective way of treating those patients, because you do the nephrectomy and you're done, while with the observation group, you do have to do serial ultrasounds to make sure that they have regressed over time. The next category, those with ureteral duplication, where you have a duplicated collecting system. As you all know, with Weigert-Meyer law, the upper pole is the ectopic ureter, the lower pole is the one that refluxes or is lateral. These could be due to, on the left-hand side, the dilated ureter with an ectopic insertion of the ureter, and on the right-hand side could be due to a URETEROCELE, and that is obstructing the upper pole system. Usually those are diagnosed antenatally, and the most common diagnosis antenatally is the dilated upper pole segment of a kidney with dilated ureter. Sometimes they can even see the URETEROCELE on the antenatal antenatal ultrasound. The management has been evolving over time. So there's the endoscopic puncture. If it is a URETEROCELE, you can puncture the URETEROCELE. In the past, partial nephrectomy was the most common operation for these types of anomalies. Today, the most common repair reconstruction is the third one is the ureterocelectomy, tapered ureteral reimplant for dilated collecting system, a complete reconstruction with excision of the uretero, and some can be managed conservatively. There's a small entity of ectopic hydronephrotic ureters that can be managed conservatively. Those are the ones that do not have function at all. And then what happens over time, the hydronephrosis improves and resolves. This is the look on the ultrasound where you have a dilated upper pole system, dilated ureters all the way down to the bladder. And as far as surgical options, we talked about the partial nephrectomy, removing the upper pole, leaving the lower pole ureter in place. What happens, the urethral decompresses. You can do a lower pole excision, especially if you're doing it laparoscopic. You can go all the way down and excise the ureter close to the bladder without going into the uretero. You can do a ureterocelectomy. Most of these are done lower than this is a ureteropylostomy, but you can do it lower, leaving the stump of the ureter, or a complete reconstruction of actually taking the ureters together and reimplanting them into the bladder with excision of the uretero. The simplest form is a uretero incision. Different ways of doing this, but incising the uretero to decompress it. One of the risks of that is forming a vesical ureteral reflux, which may become clinically significant, require intervention. But at the same time, if you do that, what the ureter is decompressed, so your ureter comes down in size to a normal size, and the feeling is much easier to reimplant a normal caliber ureter than a dilated ureter into the bladder when the lower pole ureter is normal in caliber. This is an example of a kid that underwent a ureterostomy, pre-op, post-op, with resolution of the upper pole hydronephrosis, or a partial nephrectomy, where this is a significantly dilated upper pole system with no function, what you see over here. And this is a post-op ultrasound that shows a kidney that looks pretty much normal in appearance. Most of these kidneys are smaller than the contralateral normal kidney. As far as prenatal intervention with antenatal hydronephrosis, very rare to require that. I would consider intervention if there's bilateral significant hydronephrosis, especially if it is associated with oligohydramnios, where there are no other abnormalities, chromosomal studies are normal, and that when you do multiple taps of the bladder, the parameters are abnormal. Again, a common question in the in-services and the boards is if you actually have a tap, bladder tap that's abnormal, what's the next? What would you do next? The answer is to tap again, because the first tap is not accurate. You have to tap 2 or 3 bladder taps to get an accurate diagnosis as urine parameters. And all these prenatal intervention and prenatal ultrasounds have had a major reduction in the severe congenital anomalies. A lot of these severe ones that have other abnormalities are a lot of times terminated, and therefore we don't see them as often as we used to prior to ultrasound. The other entity is posterior urethral valves. This is an example of fetal MRI of a valve. You can see the distended bladder, the dilated posterior urethra over here. Same thing here, distended bladder, dilated posterior urethra. And then severe hydronephrosis bilaterally. As far as intervention in utero, the main reason to intervene with posterior urethral valves is to prevent pulmonary hyperplasia, hopefully to improve kidney function, but that has not shown to be true, or improve bladder function. The most commonly performed antenatal intervention for posterior urethral valves is percutaneous vesical amniotic shunt, but there are more and more centers around the country that are doing fetoscopic surgery, so you can actually do a vesicostomy in kids that have gotten some have even ablated valves in fetuses. And the indications for fetal intervention, if there's 20 to 32 weeks gestation, there's no oligohydramnios with kidneys that are adequate, the chromosomal studies, no other abnormalities. The problem is that there are high complication rates with those, including prematurity, and it definitely helps the lungs, but otherwise it's questionable as far as does it actually help renal function, and the feeling is that it does not improve renal function, but allows for adequate lung function. And again, the percutaneously placing a trocar into a vesicoamniotic shunt, sometimes infusing into the amniotic sac with amnio infusion will allow for better placement and a working space. There are complications associated with that. Some of them, like over here, herniation of small bowel through the port that was inserted, or strangulation of the umbilical cord on the right-hand side here. And all of us have seen these types of complications, and that can occur with vesicoamniotic shunt. Again, the VCUG is diagnostic. You notice the bladder is trabeculated up here. This is a dilated posterior urethra that is obstructed due to valves. And this is the appearance of valves. You notice a small opening and a valve over here. Postnatally, as soon as the kid is born, the easiest thing is to put a 5 French feeding tube into the bladder. We would refrain from putting a Foley catheter because a Foley can obstruct the ureteral orifices, so it should just putting a 5 French feeding tube, checking their electrolytes, getting an ultrasound, avoiding cystourethrogram, and then any type of functional study after the valves are ablated. And you notice here on the ultrasound a dilated bladder with dilated ureters bilaterally, and an avoiding cystourethrogram that shows a very dilated posterior urethra of extremely trabeculated bladder with vesicourethral reflux. This is the way they look on ultrasound. Is you have those valves on either side. Our management is with endoscopic incision, usually with a cold knife, incising the valves at the 5 and 7 o'clock position, sometimes 3 and 9 o'clock position. I think there are long-term problems. 30% of kids with posterior urethral valves will end up in end-stage renal disease requiring transplant. The obstruction effects a lot of times are permanent. There's this thing called the valve bladder syndrome, especially in teenagers that have the distended bladder. It is felt that there's a pop-up mechanism. So, example, if you have a high-grade reflux in a non-functioning kidney, that could be a pop-off that decreases the pressure and therefore protects the contralateral kidney. That's kind of been debatable if that actually occurs or not. There's several studies that have shown that if you do get to native creatinine of 0.8 or lower, they have much better prognosis than those that have a higher creatinine, native creatinine. Another entity that can also be diagnosed antenatally is Prune belly syndrome. The prenatal findings are very distended bladder, HYDRONEPHROSIS, a very irregular and wide abdominal wall, and undescended testicles if they can look for them. So those kids are born with a very distended abdomen, like this 2 pictures over here with lax abdominal wall. We notice there's a very severely dilated bladder with high-grade reflux, megalourethra. The GU manifestation of Prune belly are several. You can get renal dysplastic changes in the kidney leading to renal failure. It's felt that the creatinine nadir of 0.7 is better, has a better long-term prognosis. You can get a dilated bladder, prostatic urethra, and ureters. And most of these kids have poor bladder emptying, reflux, megalourethra, very dilated urethra is rare. Urethroatresia also is rare. Because of these, you can actually get urethral diverticular or patent urethus, and all of these kids have intra-abdominal testicles. There are several extra GU manifestations. 100% of these will have an abdominal wall defect because there's some respiratory implications, including pulmonary hyperplasia, pneumothorax, pneumomediastinum, chronic obstruction, cardiovascular around 25%, GI with malrotation, volvulus, and omphalocele around 24%. Musculoskeletal in around 23% of these with club feet, pectus. There's some metabolic and endocrine abnormalities, and infections and sepsis are pretty common, in around 14% of these children. The categories, and get 3 categories, and you can actually see that the category 3 is the mildest form. Category 1 is the more severe form. Those are usually the category 1s are non-compatible with life, with renal dysplasia, oligohydramnios, pulmonary hyperplasia, porous features, and ureteroceles. So the way the abdominal wall looks, there is abdominal wall laxity. A lot of these kids eventually will undergo some form of surgical intervention with an abdominoplasty, pre and post-op. Those are post-op findings of abdominoplasty in these kids. This is what's called a Montfort operation, pretty much taking a bunch of skin off and then interposing the obliques on either side, leaving the umbilicus in the middle, and then doing the abdominoplasty. You see the obliques are brought and crossed over each other to create a stronger midline abdominal wall. Lastly, I'd like to talk about bladder exstrophy. I'm sure that Dana Weiss last week gave a superb talk on this. Bladder exstrophy can be diagnosed antenatally. Because of that, we are seeing a lower number of patients with bladder exstrophy than we used to before, mainly because a lot of these are terminated, especially in the European countries. Prenatally, we are still seeing kids that are not diagnosed just because of the fact that the prenatal maternal fetal medicine physicians do not recognize those. I think the important thing antenatally is if you don't see the bladder, think bladder exstrophy, and I think that's a message that needs to be clearly messaged to the MFMs in the community. Once you do that, you look for other abnormalities such as low set umbilicus, a lower abdominal wall mass, which is the exstrophy bladder, and then the genital structures are poorly defined. We've had several kids in the last several years that have basically been told that they had a female fetus and this was a male exstrophy. And those are the findings, the abdominal wall mass, the lower set umbilicus, and then you can look for diastasis of symphysis pubis and genital abnormalities. But those are things that can be diagnosed antenatally. The benefits of prenatal diagnosis is that we can optimize care. We can give and educate the families before the kid is born. If they need to schedule an induction of labor, we can talk about the surgery. Usually those surgeries are delayed, so we can actually delay the surgery, but actually plan for the surgery, and it allows continuity of care. Those are examples of the spectrum of bladder exstrophy. This is just an epispadias where you actually have an epispadiac urethra, either in males or in females. The bladder is inside and the urethra is epispadiac. And then the bladder exstrophy, where you actually have exstrophy of the bladder and an epispade at the same time. This is a male where the umbilicus is low set, the bladder is exstrophy, the urethral plate, and the penis. Again, this is pre and post surgical reconstruction. There's, as I'm pretty sure Dana Weiss talked to you about this, there's some challenges to bladder exstrophy. The bladder volume is a big component of that. A lot of these bladder plates will grow with time, some of them do not. And if they don't, then you actually have small bladder capacities, which will require some form of intervention to allow them to be continent. There's no internal or external urethral sphincter. The abdominal wall is defective. Most of these kids have inguinal hernias, the diastasis of symphysis pubis, and then genital abnormalities, both in the males with the phallus and the females with uterine prolapse. And more importantly, the psychological impact that this entity has on children with bladder exstrophy who will, over their lifetime, require multiple surgical procedures to get them to as far as normal function. This is a female with bladder exstrophy. Same thing. We have a bladder exstrophy, the clitoris, which is bifid, low-lying umbilicus. And this is we use spica cast for immobilization, but this is a post-op figure of an umbilicus. This I consider the most difficult part of pediatric urology is managing kids with cloacal exstrophy. So basically have exstrophy of the hindgut, two bladder halves. This is an interception of the small bowel into the hindgut, two hemiphalluses, and those kids, and I consider this the most difficult component of surgical management. Unlike bladder exstrophy, a lot of these kids will have prenatal abnormalities. A large majority of them will have, other than the abdominal wall defect, will have an omphalus erosion, will make the closure even more difficult. A lot of them do have myelomeningocele. And poorly defined genital structure. Their genital organs, especially in males, is diminutive, and a lot of these will require some form of of reconstruction when they get older. There's some limb abnormalities, and then kidney abnormalities, including absent kidneys, pelvic kidneys, horseshoe kidneys. This is an example of a cloacal exstrophy with a very large omphalocele. And our current management of these is a stage repair, so pretty much doing the omphalocele and the hindgut separation first to create a colostomy, leaving the bladder halves, bringing the bladder halves together in the midline, and then later on doing the reconstruction of the bladder at a later stage. There's significant long-term problems with these kids, including spinal cord abnormalities, musculoskeletal abnormalities, the omphalocele and the abdominal wall defect. A lot of them will have short gut, so there are GI consequences, especially if you're looking at kids that you would like to reconstruct. A lot of these kids will require some form of an augmentation cystoplasty. How do you do that when there's short gut and no large bowel to reconstruct? Renal anomalies, their fertility challenges, and their genitalia are underdeveloped. Finally, just for the last minute, I'll talk about lower genital anomalies of the vagina, including a UG sinus. Basically, both the vaginal and the urethral openings come together in a single common channel. And the second is a cloaca, where both the rectum, the vagina, and the urethra all come in together as one sinus to the outside, so they're basically one opening to the outside, or an absent vagina. The cloacas are divided into low or high confluence, pretty much depending on where the confluence of the vagina and and the hindgut come into the low confluence ones that are obviously easier to reconstruct than the high confluence ones. The high confluence ones have a higher rate of neurogenic component of the bladder requiring intermittent catheterization. There are different variations of this, but the main thing is there's just one opening in the perineum. The high confluence are really regarded like this one over here on the left-hand side, where the distance between the bladder neck and the vagina is less than 1.5 centimeters, and the low compliance is lower, greater than that. We're on time, 11 o'clock, and so we're done with this talk. I'm going to open this up for questions. I just need to sign off here. And any questions from the group? I don't see 27 participants. No questions? Thank you, Owen. And I think the take-home message with these kids is especially with antenatal hydronephrosis, is looking at serial imaging, not just one. There was a question, if you find an isolated epispace, any further workup? I would still get a renal ultrasound to evaluate renal function. A lot of these kids will have a normal bladder capacity. The issue is, as far as the epispace is concerned, is what type of epispace is it? There's those that are distal to the sphincteric mechanism, but then there's a penopubic. The penopubic epispace are those that have an incompetent bladder neck, and therefore continence is an issue with these kids. What we do know is that continence is directly related to bladder capacity. So if you have a normal bladder capacity, you are better able to perform a bladder neck reconstruction. And so the epispace on the whole, the epispace kids with just isolated epispace, penopubic epispace, do better as far as continence is concerned, but no other workup is required. Some of us would get a measure of the bladder capacity before we do any type of bladder neck reconstruction to evaluate them. I think the thing that has really happened over the last 10, 15 years with bladder exstrophy and epispace is the collaborative. There have been multiple collaboratives. There's one with Boston Children's Shop and Milwaukee. That is an open collaborative. There's another one in Midwest. I belong to an international collaborative in India workshop. We go there every year. Hopefully we'll be able to do so in January, but every year, and just to exstrophy closures. The concept there is we follow those kids on a yearly basis. They come back every year, we follow them and critically assess our outcomes. I think with that group, which involves 4 institutions plus multiple international individuals that come to the workshop, there have been several improvements, and I think with these types of workshops, we're able to improve the management and the outcome of these children. The question here, do you offer training opportunities for foreign interns? Yes, we would. I think the issue with foreign interns is the issue of licensing. If you do have your USMLEs, you're able to get a license within our state, then yes, you can participate in clinical work, and we do have that opportunity. On the other hand, we've had several foreign physicians who have come over as observers. So we've had several from China, India that have come over. That's another option, to come in as an observer, stay for several months as an observer, and get experience that way too. Participate in research activities if you'd like.